So when we talk about, adolescent, which age group we are dealing with? This is defined as girls and young women under the age of 20 years, according to ASHRAE. But there are many guidelines, they take the women, girls, who are less than 22 years. So when we say adolescent endometriosis, we are dealing with girls who are less than 20 to 22 years, right? Different studies have taken different. This is a real case scenario which I had dealt with. This was an 18-year-old girl. She came to my OPD. She had pain in lower abdomen for past 2 years. And this all started after her mother died. In last 6 months, she was rushed to emergency for injectable analgesics several times. She was missing her college off and on. She wasn't sexually active and she had no urinary problem. She got a urine culture done, which was normal. Ultrasound abdomen and pelvis was done twice, which is again normal. She was advised MRI pelvis, but she refused to get it done. She tried NSAIDs, OCPs with not much pain relief. And she had also seen a gastroenterologist because I had referred her, maybe it is not a gynae problem, and we are unnecessarily saying that you have endometriosis. She was advised endoscopy, which she did not get it done. So ultimately, I referred her to pain management clinic because she wasn't willing for laparoscopy. And then after that, she was lost to follow. So what is the prevalence of endometriosis in this age group? How many women and girls will suffer? So the incidence of endometriosis in adolescents, defined as girls less than 20 years, who have chronic pelvic pain, it is reported to be ranging from 25 to 73%. In patients who are absolutely normal or who have no symptoms, we really do not know what is the incidence. So if you see the major chunk of adolescents where you will diagnose endometriosis is this chunk, where these are the girls who have failed to respond to conventional chemotherapy, medical therapy. Now, if you do ultrasound, what will you find? So in 11% cases, you will find ovarian endometriomas. 5.2% you will find adenomyosis, and 3.7% you will still find DIE. The most common lesion in these adolescent girls is superficial peritoneal endometriosis, which ultrasound does not pick up. So if you do laparoscopy, right, and in how many percentage you will diagnose this? So suppose if you have done a laparoscopy for a girl who has dysmenorrhea, there are 50% chances that you will find that she has endometriosis. If you are doing it for a chronic pelvic pain where she has tried everything, you will find there are 70% chances that she'll have, endometriosis. And if you are doing a laparoscopy for a chronic pelvic pain, which is resistant to medical therapy, 75% chances that, you will find endometriosis. And what are the risk factors? We all know about it. If she has an early menarche, if she has short cycles, that means she's having more number of periods. If she has a relative family, mother, sister who has endometriosis, she is more likely to have endometriosis. If she has a history of asthma, or if she has some congenital anomaly which is obstructing the flow of menses. What clinical findings you will find in these patients? So the 2025 American College of Obs and Gynae still says that, most common finding in these girls who suffer from endometriosis in adolescent group is dysmenorrhea, right? But all other, studies, what do they say? They said symptoms of cyclical pain is seen only in 9.4% of patients. 28% they have acyclical pain alone. That means if patient has come to you with a pain lower abdomen which is not related to periods, it could still be endometriosis. And 62.5% they'll have both cyclical as well as acyclical pain. So in majority of these adolescent girls, the symptom is in 90.6% it is acyclical pain, which is the most common presenting feature. Along with this acyclical pain, these patients, girls, will also have nausea. And why do they have nausea, along with this pain? I'll be coming to that later on in my slides. And we all know, that in endometriosis, there is a diagnostic delay of 7 to 10 years. Same thing happened in these girls also because, various things are, no, it is normal to have dysmenorrhea and all these kind of things, happen and there is a delay. So, but if a patient comes to you who says that, she has a pain in groin, she has a pain in perineum, or sacrum, and she describes that this is a baking pain, cutting pain, stabbing pain, think that she has a neuropathic component, right? Because endometriosis pain will not be like this. According to ASHRAE guidelines, so in adolescents, clinicians should take a careful history and consider the following symptoms as suggestive of presence of endometriosis. And according to ASHRAE guidelines were made in 2022. Chronic or acyclical pelvic pain, particularly which is combined with nausea, dysmenorrhea, dyschezia, dysuria, and dyspareunia, plus cyclical pelvic pain. All these things, all these symptoms you can find in these girls who are suffering from endometriosis. Most important history which you should tell is she absenting from her school or from her college? As far as the clinical examination is concerned for diagnosis, it is not very helpful because they have very early stage of disease. PV, if the girl is not sexually active, you cannot do it. But if you do PR and if she has, endometriosis, you may find nodularity in uterosacral ligament. Otherwise, PV, PR, unless there's a big endometrioma, it may not give you much information. So how will you clinch the diagnosis? Before we come to diagnosis, let's see the differential diagnosis. I mean, don't just be blind. A girl who's 16, 18, she has a pain up lower abdomen, it is endometriosis. No, there could be various non-gynecological conditions also. So what are these non-gynecological conditions? IBS, right? Usually it starts at the age of 20 years in these girls. So think of that also. She could be having UTI, she could be having musculoskeletal syndrome, visceral hyperalgesia, or maybe some psychiatric problem or neurological problem. As far as the gynecological diseases which can cause chronic pelvic pain, of course, endometriosis, adenomyosis is very rare, fibroids, not very common. If she has undergone some kind of surgery in the childhood, then she could be having post-operative adherent syndrome. It could be PID if she is sexually active, which majority of these women are, ovarian masses, or she could be having hematocolpos owing to obstructive Mullerian anomalies. It could be vulvodynia, or she may be having hydrosalpinx. So what investigations you will do in a girl who has come to you with a cyclical or acyclical lower abdominal pain, So first thing is that you do a C-react, complete blood count, C-reactive protein, metabolic panel means all this creatinine, sugar, everything, Urine analysis with urine culture. Please do a pregnancy test or beta HCG. Maybe it is an ectopic which you are missing out, depending on, what patient you are dealing with, what symptoms she has. And testing for sexually transmitted infections if she is sexually active. Now, this is the new thing which I found, that, a dysbiotic gut or genital microbiota, this is associated with multiple gynecological conditions, two of important conditions, endometriosis and infertility. That means this is one factor. We do not know whether it's later on it happens or whether it's a causative factor, but the important thing is that they have a dysbiotic microbiota. These microbiomes likely play a role in the gut-brain axis, and there's a lot of research going on. So endometriosis seems to be associated with elevated levels of Proteobacteria, Enterobacteriaceae, Streptococcus, E. coli, and across various microbiome sites, they will have, dysbiotic gut genital microbiota. I mean, this gives us a thought, should we give them, something to improve their, genital microbiota? Well, it's a food for thought, So majority of them, these young girls, they are not, when they are not sexually active, we just have to do a transabdominal ultrasound to clinch the diagnosis. And it's this thing is limited, So if she has an endometriotic cyst, it can, and a big cyst, ultrasound can, transabdominal ultrasound can still diagnose. But suppose she has a small 1 millimeter cyst, how can 1 centimeter cyst? How can ultrasound diagnose that this is a typical ground glass appearance? Very difficult to visualize. In particularly superficial endometriosis, transabdominal ultrasound is useless, right? So adolescents, we know that they have an earlier stage of disease with smaller endometriotic lesion, which could be difficult to detect using ultrasonography. And, if she has say 1 centimeter endometriotic cyst and you are not sure, this has a ground glass appearance, wait for 3 months. If the cyst disappears in 3 months, well, it was functional cyst. If it doesn't disappear, it gives you this thing, yes, it could be endometriosis. Or there are indirect soft markers. What are these soft markers? Suppose if you find there's a site-specific tenderness or there's a reduced ovarian mobility. But reduced ovarian mobility always does not tell you that this is endometriosis. It could be because she had PID and ovaries are adherent. So one has to take the whole picture in toto. Adhesions may be suspected if the ovaries or the uterus move together with adjacent structures such as bladder, intestines, or pouch of Douglas. So small, deep infiltrating endometriosis nodule may be easier to identify by the tenderness-guided transvaginal sonography. So here you have to use extra gel. Normally we use 4 ml of gel. So if you put extra gel and then, with the tenderness guided, because even if she is a DIE, it will be very small nodule and only a trained eye will be able to pick up. An important thing to note is that if the ultrasound is negative, it does not rule out endometriosis. And if TVS is not possible, one should try transrectal. But I have seen in my practice, majority of girls, they refuse for it. And this transrectal ultrasound, it has a 97% sensitivity and 96% specificity for the diagnosis of rectovaginal endometriosis, which is very uncommon in these young girls. Majority of these girls have, superficial endometriosis or very small endometrioma. What is the role of MRI? Right? There is no consensus about the indications to perform an MRI. Whenever you are doing an MRI, remember you have to ask fat suppression is necessary, because suppose if she is a small teratoma, only fat suppression sequence will tell you that she has a teratoma. And MRI may pick up superficial implants, but my radiologists, they usually say, Dr. Khemani, it is very difficult to pick up. It can also diagnose hematosalpinx. And of course, we all know, though only 5 to 7% have adenomyosis, MRI is very good, in diagnosing adenomyosis. So important thing here is, why I've put this, this is a very old, article from 1987. It had said, that, glandular elements, because in endometriosis, there are endometrial gland outside the uterus. So glandular elements are usually quite small, and their color seen at surgery is due to fibrosis. They do not have any color. So what you see, yellow color, brown color, or, red color, it is all because of either fibrosis or hemorrhage. Glandular element does not have any color, right? And 81%, if you do a laparoscopy, then in 81% cases, it is either stage 1 or 2, right? While remaining 18% will have stage 3 or 4 disease. Over in endometrioma, they are frequently observed in women who are more than 20 years. In younger women, rarely we find them. Now, if you do laparoscopy, how will you identify? These are the subtle signs your eye has to be trained to pick up. Then only you'll be able to pick up. Now, if you see here, this red, lesion, here, this one. So this consists of red flame-like areas. You may find red vesicles, red polyps. And if you take a biopsy, you will find endometrial glands and highly vascularized stroma and focal hemorrhage. But though this lesion is so small, it is metabolically very active. It secretes prostaglandin F2. Because it secretes prostaglandin F2, this causes, spasm of the uterus, so the patient has unbearable pain. And this also causes a spasm of intestine. That's why she has nausea. So in this adolescent girls, pain with the nausea is, one should think, that probably this is endometriosis. Clear and red lesions, they are more metabolically active as compared to powder burn lesions, which are seen in the adult woman. Which are the common sites involved by the adolescent endometriosis? The most frequent site which will be involved is posterior cul-de-sac, uterosacral ligament, and peritoneal pockets. Infiltrating endometriosis lesion more than 3 to 5 millimeter, they occurred almost exclusively in the tissue below the ureter, right? And this is another photograph where you can see there is a peritoneal defect, right? And peritoneal defect always indicates that probably this is endometriosis. If you take a biopsy from here, you will find it is not always easy to take a biopsy because you have to see what structure is underlying it. And this is another, these are the white lesions along with some red. This is also very typical of adolescent endometriosis. Just see these subtle white blabs just above the uterosacral ligament. If your eyes are not trained and if you're not careful, if you don't go close to, so the trick of, diagnosing adolescent endometriosis is that you have to take your laparoscope close to the peritoneum. So whosoever is showing camera to you, tell that person that we do not want the panoramic view. Please just come very close to the peritoneum and you'll be able to pick up these lesions. The superficial peritoneal lesions, they are reported to be highly inflammatory. Moreover, it has been shown that clear and red lesions, they are most painful. This is another patient, 16-year-old girl. Here you see a peritoneal defect. This is another girl, she was again 16 years. Here you can see a red lesion and just see this white lesion, right? And this is just about the ureter. Now, a person, may just pick up this and may ignore this, because one actually has to be trained to pick up these lesions, This is very characteristic. We all know, nobody will miss it. But important thing is that if you are doing a laparoscopy, please lift up the ovary so that you can see the ovarian fossa. If you are not able to, if you don't lift up the ovarian fossa, if you just do, I just put in a scope, I found everything was fine and I have not created all the ports, you will not be able to move every structure. So please put all this thing ports so that, your both hands are mobile. Your assistant is also able to help you. Here you see another, case, where, if your patient had a lot of pain, and if you see here, these small lesions, they are so tiny that if you don't come closer to the peritoneum, you might miss them. This is, anybody can pick up, both uterosacral ligaments. You can see these lesions. This extensive disease presentation was found in a 15-year-old patient with stage 3 disease. This is very correct, but sometimes this kind of lesion you also find when you have just your this thing biopsy forceps has just scratched up this thing peritoneum, you may find. So one has to be very careful. Are these, so you don't disturb them before you identify them. I mean, just look at the peritoneum very carefully. So early stage lesions, they are difficult to detect even under laparoscopy. This is very important, though I've never done it, but I've read many authors quoting this. So next time when you're doing a laparoscopy for an adolescent, please try this. So what they say that these microvascularization and flimsy free floating adhesions on the peritoneal and ovarian surface, they collapse when you create a peritoneal, this thing, pneumoperitoneum. So what you should do, you fill up the pelvis with saline and you dive inside this, saline with your laparoscope, and you'll be able to visualize this better. Submerging the laparoscope underwater to suppress light reflection also aids in identifying lesion. I've never done it. So when should you do laparoscopy? Important thing is, so in adolescent with suspected endometriosis, where imaging is negative and medical treatment with NSAIDs or hormonal contraceptive has not been successful, here you can think of doing a diagnostic laparoscopy before you advise her, GnRH analog or maybe, Dynogest, So data in adolescents show that nearly 2/3 of adolescents with chronic pelvic pain are dysmenorrhea. They have laparoscopic evidence of endometriosis. Laparoscopy to confirm the diagnosis of endometriosis can be considered, but you should weigh, that patient will have, you're going to give anesthesia to patient. She can have post-operative complications. So just weigh all the pros and cons, Diagnosis can also be confirmed through history and ultrasound. But as I said, when the ultrasound does not confirm, then you have to think of the laparoscopy. So when you are doing a laparoscopy, you should plan operative laparoscopy. Take all the consents that yes, if you have found any peritoneal foci, you will excise them. If any foci is not able, you are not able, you will coagulate it, you'll ablate it. Important thing, you have seen, these days, on the Facebook, everybody has their page, all these, young, dynamic, laparoscopic surgeons. I've seen them, stripping the peritoneum, though none of the guidelines says that you should do peritonectomy, but all these young guys who are dealing with endometriosis, they just swear by it that you have to do a peritonectomy. I took I did a session with Dr. Sanjay Patel. They do peritonectomy, butterfly peritonectomy and all those in every patient. So what does American College of Obs and Gynae say? They say they do not recommend peritoneal stripping in adolescent based on theoretical consent. That means she may have adhesion formation contributing to bowel obstruction or infertility or both in persistent pain. Plus they say there's no data which shows that, peritonectomy is superior besides, ablating it, And it is very important to communicate that the stage and location of endometriosis is not directly related to the frequency or severity of the symptoms. Because after the laparoscopy, you will go and speak to the relative and you will tell them, I found just one red patch here, one small vesicle. They say, why is she having so much of pain? Because it doesn't correlate and they are metabolically very active, these lesions. There are reports in the literature about premenarchal girls having endometriosis. I leave it at this, Should diagnosis of endometriosis be confirmed by histopathology? So if you are doing a laparoscopy, you must take a biopsy. And you will be able to confirm it in 93% of cases. And if laparoscopy is performed, clinician should consider biopsy to confirm diagnosis histologically. But if the biopsy comes out negative, it does not rule out endometriosis entirely. So now the main goal of therapy is medical therapy, right? And what is the goal of medical therapy? You have to give this patient symptomatic relief, right? So that she's comfortable in life, she can attend her college and school. You have to suppress the disease progression. We all know it's a very chronic disease, and you have to protect her future fertility, right? So you have to emphasize to this patient that she has to take treatment as long as she is ready to have pregnancies. What is the best treatment for adolescents with suspected endometriosis? We all know first line of treatment is NSAIDs. So GDG recommends clinician consider NSAID as the treatment for endometriosis associated pain in adolescent with suspected endometriosis, especially if first line hormonal treatment is not option. Now, majority of girls are doctors. When I talk to, they say NSAIDs do not work. Why it doesn't work? Because you have to start these NSAIDs before she has started her periods. Because once she has started her period, these metabolically active lesions have already produced prostaglandin. So your drug will not be able to work. So start these NSAIDs in double the dosage 1 or 2 days before the onset of menses and continue it throughout the first 2 to 3 days, and they will really work wonders. This is not 2018. It is again reconfirmed in 2025 according to American College of Obs and Gynae. So ibuprofen, they say you give in 800 milligram initially, followed by 400 to 800 milligram every 8 hours as needed. Naproxen, initially you give 440 to 500 milligram, 550, followed by 220 to every 12 hours as needed. Mefenamic acid, initially give 500 milligram, but later on you can give 250 milligram every 6 hours. So recommended treatment for endometriosis in adolescents is conservative surgical therapy for diagnosis and treatment combined with ongoing suppressive medical therapy to prevent endometrial proliferation. So what I mean that, first thing is that you give medical therapy. In case you have done the laparoscopy, please continue medical therapy till she is ready for her.
Dr. Amita, please mute.
First line therapy for adolescents with either surgically diagnosed and destroyed endometriosis or presumed endometriosis include suppressive hormonal therapy. So as in adults, we give continuous combined hormonal contraceptive, either alone progesterone or 52 milligram LNG IUS. All of these methods have been shown to be effective. But patient may benefit from trying several, like she has tried one particular brand of contraceptive, it doesn't work, switch over to something else, a different regime, till you know that this is the best fit for her. So we all know these, compared to placebo, OCPs are much more effective. In adolescents with severe dysmenorrhea, the ESHRE guidelines also endorse it, that in adolescents with severe dysmenorrhea and are endometriosis-associated pain, clinicians should prescribe OCPs, or progestogens, or LNG as the first line therapy because they may be effective and safe. Because these days, every time I attend conference or something, people ask me, Dr. Khemani, are you using elagolix for adolescents? I say, no, just wait, right? So should you use continuous or cyclical OCP? So it has been seen that, cyclical, the continuous OCP is much more effective. But here in this particular study, what I found, that said that, initially, continuous oral contraceptive pill is more effective. But after 6 months, both are equal. So if patient is comfortable with having periods every month, you can give her withdrawal because see what happens in the cyclical OCP. Every time, after 4 or 5 months, the withdrawal period is very little. That's why the difference between the effectiveness is not much after 6 months. 33% of patients who are given estrogen, progestins, or progestogens do not respond to therapy, and we should accept this or whether it is an adult patient. What is the role of progestin? So progestin only method includes minipill, norethindrone. One can also use, that drosperinone, 4 milligram tablet, which is available, right? But I have not used, but I've read a lot of article on this. It should be noted that there is a small peripheral conversion of norethindrone ester to ethinyl estradiol as opposed to norethindrone. So when we are giving this thing, norethindrone, it gets converted into ethinyl estradiol. So actually we are giving this patient 20 microgram oral contraceptive pill even when we are giving her norethindrone. And it is shown to be effective treatment in adolescents, and they also tolerate it well. Medroxyprogesterone, I don't use it, but there's a lot of literature over it. But in these young girls, we should not use DMPA injection because it causes loss of bone mineral density. And this is the time when these girls, they are accruing, calcium in their bones. What is the role of Dienogest? So one Dienogest is very effective therapy. But again, the same concern, right? That it reduces bone mineral density. So here's a study, where they took 111 patients, they gave Dienogest for 1 year. And at the end of it, they found that there was a decrease in the baseline of bone mineral density by 1.2%. And when they followed these girls, there was a partial recovery. So don't use Dienogest as a first line therapy in these adolescent girls. I had met, in one conference, Romero. Romero is from Germany, and he's done a lot of work on Dienogest. And I asked him this question, should we use Dienogest or should I go for OCP? He says, Dr. Khemani, I don't use Dienogest in these young adolescent girls. My first choice of therapy is contraceptive pills. Only when it doesn't work, then I switch to Dienogest. So I thought he was very sensible. And this is another study, Visado study. And here also the pain score was, from 64, it came down to 9 by the end of 48 weeks. Because bone accretion is critical during adolescent, results of Visan study to assess safety in adolescent study highlights the need for tailored treatment in this population. Again, same thing, that think, you are, even though you give her calcium, even though you give her vitamin D, you tell her to do a lot of weight bearing exercise, but one should think of, that yes, she will have to take treatment for a long time. Are you ready for her to make her lose, a little bit of bone, not very bad, but still some amount of bone loss is there, We all know how does Dienogest work. We know it causes decedralization, which is significantly more frequent, in this group. And there's a decrease in the inflammatory factors also. So that's why Dienogest works better as compared to other progestins, And what is the role of GnRH analogs, right? So in adolescents with laparoscopically confirmed endometriosis and associated pain whom hormonal contraceptive or progesterone therapy failed, clinician may think of giving her GnRH agonist for up to 1 year because they are effective and safe when combined with the add-back therapy, right? GDG recommends that in young, this is ASHRAE guidelines. GDG recommends that in young women and adolescents, if GnRH agonist treatment is considered, it should be used only after careful consideration and discussion of potential side effect and potential long-term health risk with practitioner in a secondary or tertiary care setting. So we should not think of, jumping to start using GnRH analog. First line has to be NSAID or OCP. If it has failed, then we should move over to this along with some add-back therapy. Which add-back therapy you will use, right? So it has been seen that, if you give these girls a combination of norethindrone plus 0.625 conjugated equine estrogen. In the other group, only progesterone was given. It was found that, this particular group, combination of estrogen and progesterone, this is much better add-back therapy as compared to the plain progesterogens, right? And whenever you are giving add-back therapy, do not use oral contraceptive pills because they are not appropriate to use as add-back therapy as they negate the effect of GnRH agonists. So you have to give a combination of Primarin plus norethindrone, or you can give her combination plain norethindrone if she is not able to tolerate, because sometimes Primarin in these young also can cause nausea. What is the role of LNG IUD in these patients, right? Say there is a limited but consistent evidence that LNG IUD reduces dysmenorrhea in adults and adolescents, right? But one important thing is that suppose if you've done a laparoscopy, right? At that time you insert an LNG IUD, but after that, put her on combined contraceptive pill or progestogens for first 3 months, because LNG IUD takes some time, 8 days the endometrium lining will become decidualized. It will take some more time, for the inside endometriosis to, get reduced by this LNG IUD. And these girls don't tolerate these spotting, because every time she has a spotting, she will have pain. And she said this drug is not working. So initially only combined LNG IUD. I mean, this is recommended. I read a very beautiful paper on this. They said, if you're giving LNG IUD, please for first 3-4 months, combine it with either progestogens or oral contraceptive pills, so she doesn't have that spotting, because of which she may reject it, because after 3-4 months it will work beautifully and she will be able to tolerate it. So now another question: in a young girl where you have done the surgery, you had ablated laparoscopic this thing, you have done her, endometrioma removal, now should you prescribe her medical management? Yes. A study from, this particular hospital, they showed that, there was a recurrence even 2 to 10 years after the first procedure. And they said thus medical therapy should be continued until fertility is no longer desired and family size is complete. So even if it's an adolescent girl where you have done the surgery, don't forget to emphasize that she has to take pills even after that.
Dr. Pushpa, please mute yourself.
So in adolescent with endometriosis, clinician may consider surgical removal of endometriotic lesion to manage endometriosis related symptoms. However, symptoms recurrence may be considerable. 50% patients have recurrence in adolescent groups. So even these are the ASHRAE guidelines. They also say that after complete removal of laparoscopic lesion, please put them on some kind of hormonal therapy so that they do not have the recurrence. Because of its androgenic and potentially irreversible side effects, danazol has very limited utility for endometriosis treatment, especially in young patients, right? Now, what is the actual place for surgical treatment? The surgical removal of endometrioma in an adolescent girl should be considered in the case of progressive enlargement of ovarian cysts. Suppose if you find a girl who has, 2 centimeter endometrioma and she's relieved by, putting her on contraceptive pills or, progestogen, don't do surgery. She's comfortable. But if her pain is not relieved, or if this is a big cyst and you cannot leave it, or if there's a doubt, is it actually endometriosis? Then you should think of removing the cyst. The goal of surgery should be to remove all the visible disease to restore a normal anatomy. And you have to warn the patient that after surgery, pelvic pain had disappeared in 41.7. So it is not, 100% that pain will disappear. She'll still need medication, and it will improve in 38%. So yes, she will be benefited. When you are removing an ovarian cyst, it is of paramount importance to adopt all surgical strategies for preservation of ovarian reserve. That means when you are stripping a cyst wall is always white. Any red tissue on the cyst wall when you're stripping it, that means you are in the wrong plane. Make sure that your cyst wall is absolutely white when you're stripping it. Any blood vessels which you see running from cyst wall to the ovary, please coagulate them before you just strip the cyst wall off, because once the cyst wall is stripped off, these blood vessels will be, when you are cauterizing, then you will be cauterizing more area of the ovary. We have to preserve the ovarian tissue, And when you are cauterizing, just use pinpoint cauterization rather than cauterizing the huge areas. The vaporization of cystic capsule by means of a carbon dioxide laser has been recently proposed to minimize ovarian damage, right? We do not have laser, so I have never used it. However, the use of radical excisional surgery for superficial endometriosis may increase extensive adhesion formation, and it should not be used in. So all the guidelines is same thing, that you just burn these lesions. You don't have to strip the peritoneum. Recurrence is 40 to 50%. So all the adolescents should be put on the medical therapy after you have done the surgery. So there is also a paper, where they have used, Japanese style acupuncture, which is very safe and effective for the treatment of adolescent endometriosis. I do not know much about it, but I thought I just must mention it, Thank you very much for the patient hearing.